everyone, welcome to TryRight. This is PART-3 myself Srija. So today you're going to learn about the ICD-10-CM coding guidelines for certain infectious and parasitic diseases. So in this session you will be learning about the coronavirus infections. So how do you code? So what are the coding guidelines for assigning for COVID-19 infection? So COVID-19 infection, how it is? Infection due to SARS-CoV-2. So what does confirmed case mean? So a confirmed case of COVID-19 can be based on either provided documentation that the patient has COVID-19 or a positive COVID-19 test result. So either one is enough to assign. So user 7.1 we assign for COVID-19 infection. So what is the important rule over here? Normally, inpatient guidelines require lab confirmation, but COVID-19, it is an exception. So for COVID-19, if the provider says the patient has COVID-19, you may code user 7.1 even without test results. So do not code user 7.1 when if documentation uses uncertain terms like suspected COVID-19, possible COVID-19, probable COVID-19, and inconclusive COVID-19. So you must not assign user 7.1. So instead you have to code the symptoms, for example, fever, cough, shortness of breath, or use the exposure code if applicable. So this follows the guideline. So there is an example. There is an example of the diagnosis is confirmed COVID-19. So documentation is COVID-19 pneumonia or a positive RT-PCR test. So you have to assign user 7.1. And also you have to code for pneumonia, for example, J12.82 code. So how does the sequencing of codes for COVID-19 would be? So which code is placed first in the diagnosis list? So when COVID-19 is the principal diagnosis, if COVID-19 is the main reason for admission, so then sequence U07.1 is coded first. So followed by codes describing the complications or manifestations such as pneumonia, ARDS, sepsis, and acute respiratory failure. So what are the exceptions? So in some conditions, other guidelines require sequencing differently, such as obstetric patients, like obstetric codes come first, sepsis due to COVID-19, it follows the septic sequencing rules, and transplant the complications, like transplant the complication code first. So always check the condition-specific guidelines. So this is about the sequencing of codes. So when COVID-19, it leads to sepsis. So you must use the sepsis coding rules to determine the sequencing. So what is the coding logic for here? So COVID-19, it can cause sepsis, but sepsis rules decide which code gets first. So usually sepsis code first. So user 7.1 COVID-19. So next follow with organ dysfunction codes if present. For example, like acute kidney failure. So what is the example? So there is a diagnosis documented as sepsis due to COVID-19. So how would you code it? A41.89 for other sepsis. So this is coded as the first. So user 7.1 COVID-19, this is coded next. So you have to add the organ dysfunction if severe sepsis is present. So next is COVID-19 in pregnancy, childbirth, or the puerperium. So in pregnant patients, obstetric guidelines override all others. So whenever a pregnant patient has COVID-19, so the O98.5 series, it comes first. So then user 7.1 COVID-19 code. So followed by any complication, like any organ dysfunction. So for example, COVID-19 in a 32-week pregnant woman with pneumonia. So what is the coding order? What is the sequence over here? First, viral infection complicating pregnancy, the O series codes, O98.52. So then you have to assign the code for COVID-19, U07.1. Then followed the COVID-19 pneumonia, J12.82. So this is a sequencing order. So next, COVID-19 infection in a newborn. So newborn coding, it follows neonatal rules, not adult rules. So if newborn is diagnosed with COVID-19, you have to use P35.8 for other congenital viral diseases, and you have to add U07.1 as an additional code. So what is important? The code must reflect that the infection occurred in a perinatal period. For example, if newborn delivered yesterday, confirm COVID-19 infection. So coding is P35.8 and U07.1. So next, what is the coding order for COVID-19 in a lung transplant patient? So transplant complications other than the kidney. So COVID-19 infection in a transplant patient is treated as a transplant complication. So for COVID-19 in a lung transplant patient, so first you have to code transplant complication code T86.81. So then U07.1. So then any specific COVID related manifestation like pneumonia or respiratory failure. So why? Because transplant guidelines, they require that the transplant complication code is sequenced first when infection impacts the organ. For example, like COVID-19 pneumonia in a lung transplant recipient. So the coding order is T86.81, the lung transplant complication. Then followed by U07.1 COVID-19 and then COVID-19 pneumonia code. So next guideline is related to acute respiratory manifestations of COVID-19. So COVID-19, it commonly affects the respiratory system. So this guideline, it explains how to code the respiratory complications that occur because of COVID-19. So when a patient is admitted for a respiratory condition caused by COVID-19, so what is the coding rule? You have to assign U07.1 as a principal diagnosis. So then you have to assign the additional codes for the respiratory manifestations like pneumonia, bronchitis, lower respiratory infection, etc. Why? Because COVID-19 is the underlying cause and the respiratory condition is a manifestation of it. So next is, what are the common respiratory manifestations of COVID-19? So the guideline gives three major examples: pneumonia, acute bronchitis, lower respiratory infection. So coming to the case of pneumonia. So if a pneumonia is confirmed as due to COVID-19, so you have to assign what is the code? U07.1 for COVID-19. So then you have to assign the code J12.82 for pneumonia due to coronavirus. There is an example. Documentation says COVID-19 pneumonia. So principal diagnosis is the COVID code. Then the manifestation is the pneumonia code. So same like in acute bronchitis condition. If acute bronchitis is due to COVID-19, so U07.1 is assigned first. It is a principal diagnosis followed by acute bronchitis code Z20.8. So if bronchitis is not specified but it is linked to COVID-19, so instead of acute bronchitis, you have to assign the code bronchitis unspecified. Same in the cases of lower respiratory infection. So sometimes the provider writes lower respiratory infection not specified, and acute respiratory infection not other specified. So it is documented as due to COVID-19. So you have to assign the code U07.1, then J22 for unspecified acute lower respiratory infection. So there is an example, like the documentation says lower respiratory infection due to COVID-19. So the codes are U07.1 and J22. So why this matters to you? Because COVID-19 is always the cause. So it is coded first when respiratory complications are present. So manifestations like pneumonia, bronchitis and LRI, they are coded second because they are the effects of the disease. So you must read the documentation carefully to identify whether bronchitis is acute or unspecified. So COVID-19, it can cause many complications, right? So when coding these complications, we must correctly link each condition with COVID-19 using the appropriate ICD-10 codes. So there are some serious respiratory complications. What are those? Acute respiratory distress syndrome. So ARDS. So it is a life-threatening lung condition where the lungs become severely inflamed and filled with the fluid. So patients have extreme difficulty in breathing and they need ventilator support. So what is the coding rule? If acute respiratory distress syndrome is due to COVID-19, so you have to assign U07.1 for COVID-19 and J80 for acute respiratory distress syndrome. So the COVID-19 is written first because it is the cause and ARDS is the manifestation. So second complication is the acute respiratory failure. So acute respiratory failure, it means the lungs cannot adequately exchange the oxygen and carbon dioxide. So it is more severe than a simple breathing difficulty. So what is the coding rule for respiratory failure due to COVID-19? You have to assign U07.1 for COVID-19 and J96.0 for acute respiratory failure. So again, COVID-19 is the underlying cause. So it is coded first. So next condition is non-respiratory manifestation of COVID-19. So COVID-19, it can also affect other organs, not just the lungs. So examples include viral enteritis, which is diarrhea or vomiting due to COVID-19, myocarditis, which is heart inflammation, encephalitis, brain inflammation, and loss of taste or smell. So what is the coding rule? If the reason for visit or admission is a non-respiratory condition caused by COVID-19, so you have to assign U07.1 COVID-19 code as the principal or first listed diagnosis. So then you have to assign the additional codes for the specific condition. Example K52.9 for viral enteritis. So this clearly shows the COVID-19 caused the non-respiratory problem. So next is exposure to COVID-19. So this applies to the people who have no symptoms but may have been exposed to COVID-19. So example like close contact with a COVID-19 patient, workplace or household exposure, or contact tracing this situation. So what is the coding rule? For asymptomatic individuals with actual or suspected exposure, so you have to assign Z20.822 for contact with and suspected exposure to COVID-19. So this code, it is used only when the person has no symptoms and no confirmed infection. So what is the cause and manifestation principle? So you have to always code U07.1 first when it causes another condition. So this follows the rule of etiology, cause, or manifestation, effect. So when not to use U07.1? So you should not use U07.1 if the patient only has exposure. So you have to use Z20.822. The COVID-19 test is negative or pending without symptoms. So symptoms are present, but COVID-19 is not confirmed. So you have to use symptom codes like R05 cough and R50 fever. So what is the severity and documentation? So accurate coding, it depends upon the clear documentation in the medical record. So you have to look for due to COVID-19, secondary to COVID-19, or associated with COVID-19. So these words justify the linking codes. And for symptomatic individuals with exposure to COVID-19, so if a patient has symptoms like fever, cough, breathlessness, and they have had actual or suspected exposure to COVID-19, but COVID-19 test is negative or results are inconclusive or result is not yet known. So you have to use code Z20.822, contact with and suspected exposure to COVID-19. So why this code? Because the person had exposure plus symptoms, but COVID-19 is not confirmed. So we cannot code U07.1 unless it is clearly documented confirmed COVID-19. So if COVID-19 later becomes confirmed, they changes to U07.1. So F guideline is screening for COVID-19. So screening means no symptoms, no exposure, but being tested as a routine process. Examples like pre-operative testing, employment screening, travel screening, hospital admission screening. So you have to use code Z11.5 to encounter for screening for COVID-19. So screening is not equal to suspected case. It is just testing as a routine check. So next, signs and symptoms without definitive diagnosis of COVID-19. So this applies when a patient has symptoms that could be COVID-19, but COVID test is not done or COVID test is pending or doctor hasn't confirmed the diagnosis. So in this case, do not code COVID-19. So instead you code the symptoms that the patient has. So examples like R05.1 for acute cough, R05.9 for cough unspecified, R06.02 for shortness of breath, or R50.9 for fever unspecified. So why to code symptoms? Because coding rules require a diagnosis to be confirmed. So symptoms alone cannot be coded as COVID-19. So if a patient has signs or symptoms of COVID-19 and he has had actual exposure or a suspected exposure, so you have to then assign Z20.822 code, which is a contact with and exposure to COVID-19 as an additional code. So why there is a need of additional code? Because the main reason for the visit, it may be the symptoms, but exposure is a clinically relevant factor, so it must be coded. So how do you code in the cases of asymptomatic individuals who test positive for COVID-19? So this refers to the people who have no symptoms, but their COVID-19 test is positive. So even if they have no symptoms, they are still considered to have COVID-19 infection. So thus the correct code is U07.1 for COVID-19. So asymptomatic positive is still a confirmed case. So do not use this Z20.822 exposure or Z11.52 screening once it is positive. So next guideline is personal history of COVID-19. So this applies when the patient has COVID-19 in the past, has completely recovered, has no ongoing symptoms or complications. So in this case, which code you have to assign? Z86.16. So what is personal history code used for? So it tells that the patient had a past illness that may be relevant to the future care. So examples where this might be used: if a patient attending a checkup and mentions having had COVID previously, or documentation purposes in the medical records, or long-term follow-up or research cases. So next guideline is about follow-up visit after COVID-19 infection has resolved. So this applies when the patient previously had COVID-19. So they are no longer have symptoms, their test is negative now. So they are coming for a follow-up evaluation to ensure the recovery. So what are the correct codes? Z09 for follow-up examination and Z86.16 for personal history of COVID-19. So you have to use Z09 only when the illness is resolved, or you have to use Z86.16 to show the patient had COVID-19 previously, or do not use U07.1 because the infection is no longer active. So next is follow-up visits after COVID-19 infection. So what does it mean? So if a patient comes for a follow-up visit because they had COVID-19 earlier and now they have symptoms or conditions related to the previous infection, so you must follow the guidelines under IC1G1M and IC21C8. So when a patient has recovered from COVID-19 but it still needs medical evaluation for lingering symptoms like cough, breathlessness, fatigue, so this is considered as a follow-up visit. So you have to use specific codes to show that the current condition is related to a previous COVID-19 illness. Encounter for antibody testing. So what does it mean? Encounter is, it is a reason that patient is visiting the healthcare provider. So when a person comes only for antibody testing and it is not to detect a current COVID-19 infection, or it is not a follow-up test after having COVID-19, so you have to use code Z01.84. So which is the encounter for antibody response examination. So why this is important? Antibody test, it check the past exposure, not correct infection. So you should not use COVID-19 infection codes unless the testing is linked to confirm an active infection. So if the antibody test is done to check for an active COVID-19 infection, so then follow the main guidelines for COVID testing, not Z01.84. So this is how you code for antibody testing. Multi-system inflammatory syndrome. So what is MIS? A rare but serious condition where multiple organs become inflamed. So it can occur during a COVID-19 infection after a past COVID-19 infection. So coding when multi-system inflammatory syndrome and COVID-19 assigned, when they occur together, if a patient currently has both MIS and COVID-19. So you have to assign COVID-19 code first, which has a principal or first listed diagnosis, and M35.81 for multi-system inflammatory syndrome as additional diagnosis. So coding when MIS occurs after the previous COVID-19. If a patient who previously had COVID-19 later that develops MIS. So you have to assign M35.81 for multisystem inflammatory syndrome, U09.9 for post-COVID-19 condition unspecified. So this combination shows that MIS has happened as a consequence of the earlier COVID-19 infection. So you have to always identify the purpose of the visit first. So ICD-10 coding depends heavily on why the patient came, whether the infection is current or past, whether symptoms are new, ongoing, or post-COVID complications. Okay. So MIS with previous exposure to COVID-19. So what does it mean? If a patient has a known or suspected past exposure to COVID-19 and there are no current active COVID-19 infection and he develops MIS. So you have to assign the following codes. So first MIS code M35.81 followed by contact with and exposure to COVID-19. So there is an example. If a child had exposure to a COVID positive parent 3 weeks ago, never tested positive and now develops multisystem inflammatory syndrome. So you have to code both MIS and suspected exposure. So if MIS caused any complications like myocarditis, shock, so you must also code those complications too. Next, post-COVID-19 condition. So this section, it deals with the conditions that occur after the person has recovered from COVID-19. So when to use U09.9, the post-COVID-19 condition unspecified. So when to use, when to assign this? When a patient has sequela of COVID-19 such as fatigue, chronic cough, headache, shortness of breath, neurological issues, MIS occurring later. So what is the coding rule? You must assign code for the specific symptom or condition. Example like R53.83 for fatigue, R05.9 for cough, and also U09.9 for post-COVID-19 condition. So very important rule is U09.9, it must not be used for current COVID-19 infection. So if the patient currently has active COVID-19, you have to use U07.1 but not U09.9. So if the patient has both a previous COVID-19 related condition and now he has a new active COVID-19 infection, so then you have to assign U07.1 for COVID-19 for current infection and U09.9 to show there are ongoing problems from a previous COVID infection. So you have to code for both the old condition as well as the new symptoms. So there is an example. If a patient recovered from COVID-19 earlier and still has fatigue, so now they get infected again with COVID-19. So what are the codes you have to assign? U07.1 for current COVID infection and R53.83 for fatigue, U09.9 for post-COVID condition. So this is about what the rules regarding post-COVID-19 condition. So next is under immunization for COVID-19 status. So this section explains how to code a patient's COVID-19 vaccination status using ICD-10-CM Z codes. So this codes helps to document whether a patient is unvaccinated or partially vaccinated. So they are not the diagnosis codes but status codes that show the patient's immunization level at the time of the visit. So you have to code Z28.310 for unvaccinated for COVID-19. So when to use this code? You have to use Z28.310 when the patient has never received any COVID-19 vaccine or he has received 0 doses for any COVID vaccine type. Example, if a patient comes for a routine checkup, when asked about vaccination, so they say they have never taken any COVID-19 vaccine. So you have to assign Z28.310 in this case. So next is code Z28.311, partially vaccinated for COVID-19. So when to use this code? You have to use Z28.311 when the patient has received some but not all recommended doses. So according to CDC guidelines at the time of the visit. So why timing matters? Because vaccine recommendations change over time. For example, 1 dose, 2 doses and booster doses. So the patient is considered partially vaccinated if they have not yet completed the current recommended series. So the first example is patient received only one dose of a 2-dose vaccine. So you have to assign Z28.311 code. Second example is patient completed the basic 2-dose series but did not receive the recommended booster at the time. So you have to assign Z28.311 code only. So you have to think this code as an incomplete series. So next is vaccine guideline reference. It mentions the CDC website where updated vaccine schedules are available. So this matters because the definition of fully vaccinated changes over time. So coders should check the recommendations active at the time of the encounter but not the older rules. So next, coming to documentation section reference. So when documentation of vaccination status comes from someone other than the patient's provider, for example like school records, employee records, immunization card. So this explains whose documentation can be used when coders can rely on non-provider documentation. So these codes do not indicate COVID-19 infection, vaccine side effects, immunity level. So they only reflect the vaccination status. So these codes, they are often used during routine health visits, pre-employment exams, school physicals, hospital admissions, and public health assessments. So they may impact the risk stratification, treatment decisions, and infection control measures. So this is about under immunization of COVID-19 status. So this is for today's session. I hope this session has helped you. So in the next session, you will be learning about the chapter 2, that is neoplasms coding guidelines of the ICD-10-CM. Thank you.